Good morning. Happy New Year and welcome back to Global Neurosciences Institute Grand Rounds. And now it is my great pleasure to introduce today's speaker, Dr. Ausim Azizi. Dr. Azizi received his MD PhD degrees from Southwestern Medical School in Dallas, Texas. He then completed his graduate work, internship, and neurology residence at Yale New Haven Hospital. He is board certified in neurology, neuroimaging, and neurocritical care. Dr. Azizi is an active clinician, a fellow of American Academy of Neurology and American Neurological Association, and has been elected as a top dog by Philadelphia Magazine for the past 14 years. He was trained as a neuroanatomist and neurophysiologist, publishing a body of work on neuromorphology. Later, his lab pioneered exploring the use of bone marrow stem cells for treatment of neurologic disorders. Dr. Azizi is a reviewer and editor of multiple neuroscience journals. Dr. Azizi has participated in neuroscience education and development of medical school curriculum from first-year medical school programs to continuing medical education and has trained numerous students and residents. He has given invited local, regional, national, and international lectures and has received many teaching awards. He was invited to become a visiting professor at the Mayo Clinic as well as the University of Pennsylvania. Today, Dr. Azizi will be speaking about seizures and epilepsy. And Dr. Azizi.
Thank you, Peter, for that kind introduction. Can everybody hear me okay?
Yes, we can.
Good. So I'm going to talk about seizure and epilepsy. It's not going to be a wonkish talk about any nuances of seizure or epilepsy. During my teachings, the residents, medical students, particularly the primary care physicians, you realize that there are some misconceptions and some problems with definitions of seizure epilepsy and understanding of pathophysiology and mechanisms. So today I'm going to gear my talk more basic towards what causes seizures, how does it come about, and how to approach them. I have no conflict of interest or commitment. And the objectives of this lecture or this discussion, I should say, is, and I mean that by discussion is that please interrupt me if there is anything that is not clear, and also the questions at the end. To clarify some definitions and terminologies about seizure and epilepsy, talk a little bit about the epidemiology and etiology of seizures, what brings on seizures. And then what are some clinical presentations and classification of seizures? And concentrate the last quarter of the talk on pathophysiology and a little bit on treatment, because the treatment is basically pretty simplistic. So what are some definitions that we talk about? Every time I ask a medical student to define a seizure, they're going to say, oh, it's increased electrical activity in the brain. The actual definition of a seizure is not increasing or decreasing electrical activity, and it's an abrupt cessation of transient or abrupt and transient cessation of brain function. It's function in quotes in there, because I'm going to go back on that as to what function literally means. People have non-epileptic seizures and they do not have any increase in their electrical activity in the brain. So a seizure, the global definition of seizure is an abrupt and transient cessation of normal brain function. Clinically, the way it presents, it's usually with positive symptoms. The nuances of how it presents and whether there's tonic and clonic and cursing and chewing and gylastic and so on and so forth, those are a little bit different and they depend on the location of where the seizure is coming from. But mostly the symptoms of seizure are positive symptoms, as opposed to, for example, a stroke or multiple sclerosis that have negative symptoms, and they're usually presenting with loss of function. The reason I kind of put that was because of the last two bullets. An epileptic seizure is a disruption of brain operation and function, whereas a non-epileptic seizure is a disruption in brain function only, not the operation. What do I mean by operation and function? If you look at this diagram, essentially starting from the left, a blueprint is the genetics that and post-translational modification that produces the proteins that generates an architecture. The architecture is the arrangement of neurons, glia, and other connections, as well as the intracellular components that allows the brain to operate. And the operation essentially means that there are these barrages of action potentials that circulate in this architecture, and that gives rise to a function, which is the observable work of the brain. If we take this and make an analogy with a car, a blueprint of a car is the maps that an engineer makes how to make a car. Then a car is manufactured, then the architecture, specific architecture of a car, which is an engine, there's wheels and axles and transmission and so on and so forth. That's the architecture. The operation is when you put gas in the car and the car engine starts working and spins the wheels. That still is not a function. The function is when the car takes you from A to B. So if you look at the brain on these last two things, when the operation doesn't work, that means there is something wrong within the brain, that then it gives rise to a problem in the function, which is the cessation of the whatever brain was doing at the time, it stops doing that. So as such, epileptic seizure is a disruption in brain operation and function. So when someone has a problem in the operation, in other words, the action potentials that are firing in the brain are in the wrong route, or they're not firing the correct way, and they don't produce a correct pattern, you're going to get a problem with the function, and that problem with the function is a seizure. And it's often abrupt and transient. Whereas a non-epileptic seizure, a seizure that is still can be seizure, let's say a psychiatric conversion disorder or a functional neurologic disorder, does not affect the operation of the brain. So if you take an EEG, the operation of the brain is fine, whereas there is no, but the function is disrupted in there. And the difference between epilepsy and seizure is that epilepsy is a brain sickness. It's a disease that's characterized by recurrent spontaneous seizures, whereas seizure is the symptom of epilepsy. And in the past, it was called the falling sickness. Even Caesar apparently had seizures, and Dostoevsky had seizures, and a number of prominent people. But seizures obviously have been there through the millennia and through the time that humans have been there. Yeah, animals have seizures. So an epilepsy is a brain sickness, and its symptoms are seizures. And then we kind of banty around about this term called provoked seizure. Is there such a thing as provoked seizure? Provoked seizure often refers to a single seizure that's secondary to external factors, for example, toxic, metabolic trauma. Oftentimes these patients, the practical part of it is that oftentimes these patients come into the emergency room, and when they come into the emergency room, say, oh, it was provoked because of heat or alcohol or so, and you send them back. People who have gray hair, they don't think there is such a thing as provoked seizure. They took a number of healthy medical students about 30, 40 years ago, drove down their glucose to about 5, and nobody had a seizure. This was done here at Jefferson by Sperling. So we know that provoked seizure actually signifies something, that there's something wrong in the brain, whether it's provoked or non-provoked, but that's a debatable thing. And that comes in terms of treatment, whether you approach it as to treat it or not treat it. Some more definition, we use this Greek word called ictal or ictus as seizure. We know that there is something called post-ictal period. It is the period that's after the positive phenomena of seizure. For example, if someone has convulsion and they don't recover completely to baseline, we call that post-ictal. The point I was going to make about the post-ictal period, or this term, is that it does not have a specific time. It could be seconds or days. The longer the post-ictal period, in other words, the patient doesn't recover from a seizure, the more it's indicative of a structural lesion in the brain. In other words, if someone has a seizure and they don't recover, you know that that brain has a structural lesion. There might be a tumor in there, there may be a large stroke or something else. So the length of post-ictal period is important, and the definition obviously is there. There's also a thing called interictal period. The interictal period is the time between the seizures. In other words, someone has a seizure, and then for a couple of months, they don't have a seizure, and then have another seizure. That those 2 months or so between the two seizures is called the interictal period. Now, the reason this is significant is because seizures come from abnormal brain. That means that that abnormal brain during non-seizure period is not going to function normally. So if you know a little bit more about the interictal period, you can say, oh, this is a temporal lobe epilepsy. For example, people who have temporal lobe epilepsy and lesion in the temporal lobe have the temporal lobe syndrome, which is hypergraphia and occasionally obsessive compulsive type of things, or they hear musical sounds and so on and so forth. Another set of terminology are the auras. Auras are positive sensory phenomena that are experienced around the time of seizure. And the seizure could by itself be aura. The point about the aura is that the aura is a seizure itself by EEG. It just happens to be in the sensory area of the brain. In other words, if you look at the cerebral cortex here and you draw a line from the central sulcus down to the Sylvian fissure, the back of the brain is a reception area. That's the sensory area. So if you have a seizure in the back of the brain in this occipital cortex, you'll have visual auras. Auditory or olfactory auras come from the temporal lobe. Sensory auras come from the parietal lobe. And then convulsions go from the frontal lobe. So it's a pretty simplistic thing that aura is a seizure, but it just happens to be in the back of the brain. So those are some definitions that I wanted to kind of clarify. So let's move to epidemiology, because epidemiology leads us to etiology of diseases in general. In the US, approximately 2 to 3% of the population experience a seizure during their lifetime. Doesn't mean they have epilepsy, but they experience a seizure. And that, if you calculate that and multiply it by the population, is about just about 12 to 13 million people. That's a lot of people to have a seizure during their lifetime. The incidence of epilepsy is higher than in infants and children, and then in the older people. In the middle, it's kind of low. Children usually suffer from primary generalized seizures, and these are usually genetic or developmental issues, so the brain is not constructed right, whereas adult and elderly usually have acquired epilepsy because they haven't had any seizures during their life. They start having a seizure in later life, and that's because something happened to the brain, and those we will discuss those etiologies in just a bit. So what are these etiologies? According to 2017 International League Against Epilepsy, the majority of seizures that are here in the left in the blue, 95% of them, are these three things. They're either genetic, structural, or unknown. Unknown also lumps itself into the genetic. The genetics are generalized epilepsy. There is a childhood absence epilepsies, juvenile absence epilepsy, juvenile monoclonic epilepsy. These are kind of common things that are sometimes benign, sometimes malignant, but these we know that they are genetic. Temporal lobe epilepsy is a structural. And then we have heard a whole bunch about this pink area here from Dravet and gylastic epilepsy, viral encephalitis. And unfortunately, because doctors in general are zebra hunters, we always kind of gravitate and try to rule these things out. The fact of the matter is that only about 5% of seizures can be these strange seizures that are fancy names, and they come in the exams all the time for students. But the majority of seizures that we talk about are basically structural or genetic in children. So let's kind of dig that further. The genetics of epilepsy, if you look at these epilepsies that are known to be genetic, which is childhood absence, cryptogenic, focal epilepsy, juvenile absence, juvenile myoclonic, temporal lobe epilepsy. A lot of pediatric epileptologists see these a lot. but general neurologists and general neurosurgeons, we don't see these things. And the genes that are associated with them are kind of listed over here. The problem with a lot of these are that the evidence, as you can see, doesn't even cross the 50% barrier in there. So there's like only 20 papers showing that these genes are associated with these epilepsies. So the genetics of epilepsy, while it's there like an elephant in the room, and a lot of epileptologists think that even normal people who have a trauma in their head, they're not going to have, some have epilepsy, some don't. And the ones who do have epilepsy because they have a genetic predisposition for it. And all we have to do is to dig enough to find it. Problem is that you dig enough, you can find anything. So right now, that's not necessarily a practical thing or anything to really worry about. We can kind of think about the genetics and know that it's there, and there may be a structural problem in people. There are some seizures, especially the ones that I noted here, and those pink ones that I noted, are real genetics. There is genes and malformations in there. And those we can encounter at times, especially in neurology and epilepsy. But the vast majority of people, the 95% that have seizures, are going to be the acquired or, and children, some genetic epilepsy that we already know about. Okay, we talk about acquired seizures. The simplistic way that I teach medical students is that if you look at this list of things on the left side, there is trauma, infection, neoplasm, degenerative diseases, and developmental diseases, stroke, and the acronym is TINDS. All of these affect the brain, and manifestation of this abnormality in the brain that becomes epileptic is seizures. And so epilepsy can come about because of any of these, especially trauma. Anytime you traumatize a brain, you're going to have epilepsy, especially if it's visible cortical lesion. Obviously, we know that neoplasms and degenerative diseases are associated with seizures. And Alzheimer's patient has about 30% higher risk of seizure than normal population of the same cohort. There are developmental issues, and stroke is a major, probably 90% or maybe the sole cause of seizures in older population. If you go by age, we see that between ages of 0 and 5, the x-axis is age, and the y-axis are some names of what the etiology of these seizures are. If you take those etiologies that I mentioned here by age, you're going to see that genetic, developmental, and benign genetic are in the childhood area. So this line is drawing in there. So 0 to 5 age have genetic developmental seizures. 6 to 15, some of them are benign, some of them are malignant genetic, that usually causes reversal and development. Ages of 16 to 30, the major cause of seizure or of new onset seizure is trauma. And if a middle-aged person come to you for no reason and they have a seizure, you always think of a neoplasm. And obviously in older people, we are thinking of stroke as the etiology of seizure. So on top here, genetic developmental versus acquired epilepsies. In other words, innate or genetic epilepsy versus acquired. Generalized seizures are often genetic. Partial seizures are often acquired. There are some forms of partial seizures that are genetic, but again, those fall into that 5 to 10 percentile that are not very common. So the common seizures, if they are generalized seizure, and we can see that they're generalized, they're usually in children, they're genetic and developmental. Whereas acquired seizures, which are because of a tumor, trauma, infection, etc., are usually in older people, and they are partial epilepsies. In other words, they start in one part of the brain. They may generalize or they may not generalize. All right. Now, the other thing that I alluded to in that pink part was there are some fancy names, for example, gylastic epilepsy, orgasmic epilepsy, abdominal epilepsy, and so on. What causes those kind of seizures? Do they have a specific pathophysiology that, let's say, causes someone to laugh during a seizure or have a convulsion. The point I'm making here is that the answer to that is no. It's simply because the lesion is in a location that causes activation of that particular behavior, which is a positive symptom, a positive abnormal symptom. So a type of seizure depends on the location of injury. So real estate in the brain, as always, comes in again. Seizure in the cerebral cortex is location of injury or seizure in the cerebral cortex. It's responsible for the phenotype of seizure or manifestation of seizure. So for example, if you have tonic-clonic or convulsions, these kind of seizures come from the front of the brain usually. If you have absence seizures, it comes from two places. One, you either cut the cerebral cortex from the periphery, and that's why thalamus is involved in there, or you can have absence seizure because the seizure is coming from the back of the brain, the connection of the brain to the environment, and because of that, you don't have any motor problem, but you have a cutoff or connect of the connections of the cortex from the periphery. The other thing that we encounter a lot in seizures are dysautonomias. During seizure, usually, for example, I look at people's eyes and see if the pupils are large. That's not pathognomonic, but it's one of the things. There are automatisms. These are because of the insular lobe epilepsies. So it's the same seizure that happens to be in insular lobe causes dysautonomia, sudden death during epilepsy, and so on and so forth. Temporal lobe epilepsies are very interesting because temporal lobe is an area of the brain that is kind of the small end of the funnel of information. In other words, visual, auditory, somatosensory, olfactory information all go to the temporal lobe. So if you have a seizure in the temporal lobe, the manifestation of that is a formed manifestation. So you often get some psychiatric things. People hear music, or people laugh during their seizure, or they have a rising feeling in their abdomen, or they smell weird things, and so on and so forth. So these are, the temporal lobe is responsible for those kind of seizures. And sometimes, the reason I kind of brought this up, obviously, it's very obvious that that should be the case, is that occasionally, for example, gilastic epilepsy, hamartomas, and the hypothalamus is associated with epilepsy. That doesn't make absolute no sense. It's just a lesion that happens to be close to the temporal lobe that's causing the laughing. It's not because a specific hamartoma in the hypothalamus is going to cause epilepsy. So again, just to drive that same point home, if you have seizures in this red area in the front of the brain, if you can concentrate on the B figure in here, then all of these will end up having motor components or convulsions, whereas if seizures are confined to the back of the brain in the green and yellow and blue and purple area, then you'll have only auras, and a mixture of them is going to start from aura and goes forward. The reason aura comes first and then gets into a seizure is because often the auras come from the temporal lobe or from the parietal lobe area. And after that, you have a convulsion that then the spread of the seizure, as a fire spreads from the temporal lobe into the frontal lobe, and you get an aura followed by the convulsion. Okay. The other thing about the seizure that is going to be important and has bearing in terms of a seizure, a differential diagnosis of seizure. In other words, is this a seizure or is it something else? We have to do an EEG to find out whether this is a seizure. Something to remember about a seizure is the seizure, even in the EEG, has a beginning, a middle, and an end. So in other words, it is a constructed temporal course. An aura comes first clinically, a seizure comes second, and a post-ictal period comes last. This is kind of the architecture or temporal architecture of a seizure. When you look at an EEG, you will see that during the aura, seizure is in the back of the brain. During the ictus, the entire brain is caught. And then once the seizure stops, you have the post-ictal period because the normal firing of the brain isn't back to normal, and so on. Now, another point that is relevant to this is that we usually do EEGs. And obviously, if an EEG shows an aura and seizure and post-ictal, that's great. You catch a seizure. But oftentimes, when like 99% of the time, when we send people for an EEG, the EEG is either normal or shows some sharps or there's no thing. So we kind of glean evidence from an interictal EEG whether this person has a seizure or not. And sometimes just by looking at those EEGs, and because there are several sharps in there, we think, oh, there may be some seizures in there. And the answer to that is no. A seizure has an aura, a middle, and an end. And if you want to capture a seizure, you got to capture it during a long-term monitoring. And that's how it's going to work. And not every swallow that flies is a flock. In other words, not every sharp that you see in EEG is a seizure. A seizure has to have a temporal architecture. Okay. The differential diagnosis of seizure is syncope, episodic movement disorders, metabolic encephalopathy. In consult service, we always get consulted for the third bullet a lot, and for the syncope, obviously. Syncope is a cardiac issue, not a seizure, but it's very difficult to differentiate. There are only a couple of functional or clinical clues that differentiate syncope from seizure. One of them is the length of time. A syncope is usually seconds. A seizure is usually minutes. So it's seconds versus minutes that separate syncope and seizure. Second, during syncope, you usually don't have a lateral side of the tongue bitten. In other words, your tongue is not chewed up. You can cut the tongue or have a laceration, but not biting the tongue. And with seizure, you do that. Everything else is kind of fair game. You can lose your urine during syncope. You can have convulsions during syncope. There's a thing called convulsive syncope. So that clinically becomes a little bit of a difficulty. So we kind of get the thing as to whether this is syncope or seizure. We do a bunch of testing, and that's usually we look at the cardiac, we look at an MRI and all that. I have seen people who don't know episodic movement disorders, diagnose them as seizures. And metabolic encephalopathy, as I mentioned, is a big deal. So you go to the kidney unit, or people who have liver or kidney problems, and they have asterixis, and the asterixis gives them myoclonic jerks. And these myoclonic jerks usually is because of encephalopathy, that's not seizure. Hypoxia is another thing. In the MICU, we are consulted often for jerky movements of patients who were found down in the field because of hypoxia. That's not a seizure. And the reason, again, is because of the last slide that I said, the seizure has a beginning, a middle, and an end. When someone is continuously jerking and talking to you, you know that that's not a seizure. It's a different thing, and it has to be treated differently. Cardiac arrhythmias can have convulsions associated with them. And obviously a big deal here is the functional neurologic disorder. And this, in my mind, should be a psychiatric thing. It just because it shows up as a neurologic symptom, it should not be a purvey of neurology. We should immediately after diagnosis, we should send these patients to psychiatry because it's a conversion disorder, and it's not really, we can't really treat those things very well. Okay, the old classification was talking about partial seizures and generalized seizures. I think that's still very useful to look at and be aware of, that there are simple partial seizures that where consciousness is not impaired, and complex partial seizures where consciousness is impaired. And then generalized seizures usually are genetic and developmental, and secondarily generalized are focal to generalization. The new classification is completely different. I think a lot of the new classification is doing two things. They are kind of paying homage to geneticists and this whole thing of smart medicine and on and on. And then the other thing it does is that it pays homage to how to collect money, because ICD-9 and 10 all have to do with specificity. And if you're specific in a certain way, then you can collect money, otherwise you can't. So in terms of pathophysiology, There are these 3 or 4 bullets that I'm going to go through in somewhat of a detail. First of all, an epileptic seizure is a disruption in brain operation. I mentioned that, and I'll explore that a little bit further. Number 2, it's kind of like a dictum. Seizures emanate from the cerebral cortex. Other parts of the brain do not cause electrical epileptic seizures. And I will explain the reason for that, as to why seizures are basically the final outcome of a seizure is the cerebral cortex. Number 3, a seizure is not increasing activity or decreasing electrical activity. It is a synchronization of the pattern of pyramidal cells. So basically a seizure is in the cerebral cortex and specifically in the pyramidal cells in the cerebral cortex. And what happens to pyramidal cells, they are not increasing their activity or decreasing their activity, but what they're doing is they're losing their pattern by synchronizing. So it's kind of like looking at your screen in front of you, and that screen suddenly either becomes very bright or goes blank or has blotches in it. That's a seizure. It's not because that screen is hyperpolarizing each pixel in there or depolarizing. That doesn't happen in the brain. Basically, the pattern is lost. Number 4, a seizure circuit develops over time. Okay, oftentimes, especially again in consult service, we hear, well, but the trauma was 10 years ago. Well, it takes that much time, A, for the circuit to develop, and B, for the second punch to come on, which could be drinking alcohol, not sleeping overnight, and so on. And that could be weeks to years later. That period is called the period of epileptogenesis, i.e., you put a trauma to the brain and take a tumor out and all that, the patient is doing perfectly fine. 5 years later, they can have a seizure. That is totally kosher. It's related to that trauma as long as there is a lesion in the cerebral cortex. And then finally, a seizure is similar to a cardiac arrhythmia. You have to develop a circuit of arrhythmia, either by ischemia, toxic metabolic tumor, etc., in order to get a seizure. So let's talk about the first bullet. The first bullet, I said that the seizure is a disruption of the operation of epileptic. The reason this is practically important is because we always get an EEG. An EEG is a very small glimpse into the operation of the brain, whether the brain is operating right or not. And we think of the brain operation as these circles that are overlapping and they're kind of going every which way, and there are these arrows that are coming and going. So if you think of the brain, this is really not chaotic, but there is a structure to it. The structure is this loops. So the brain operation is, if you think of each one of these circles as a loop or a highway that goes around towns and cities and kind of facilitate the flow of traffic. And then when you want to get somewhere, you hop on a loop and you get off at a different accent and you hop on a different loop. That's how the brain action potentials operate. So in other words, if you give a sensory stimulus and say, okay, go somewhere to this brain, and this brain says, okay, and now I'm going to start walking, you'll kind of drop that information here, either in the auditory or visual or some other sensory, and then the brain kind of goes through this function. That's the operation of the brain that then generates a function in there. So when you knock out that operation, you're going to have a seizure. That's sort of as simplistic as that. And I'm going to explore that a little bit more with the EEGs. And the reason, and the other piece that I was saying here is that seizures emanate from the cerebral cortex. And the reason for that is the geometrical arrangement of pyramidal cells. Because when you have the pyramidal cells, if we all know, the bottom of the pyramidal cells, the axons are going towards the core of the brain, the dendroids come up to the top, and they're all kind of next to each other, and what's called electrically, they're called dipoles. A collection of these dipoles or pyramidal cells form batteries. So if you put a bunch of cells together, you form a battery. That battery produces electricity, and that electricity is recorded by EEG. EEG is obviously recording. So when you talk about an EEG, it's the recording of the cortical and specifically pyramidal neurons that are firing. It's not anything else in there. And when you talk about spike and wave, that is a hallmark of an epileptic seizure. These are representation of synchronization of the pyramidal neurons, not because they're hyperfiring or hypofiring, but because they are kind of slow synchronized. And here's a picture to kind of show that. As we know, there's no dispute that this is the architecture of the cerebral cortex, right? You have layer 5 pyramidal cells, layer 3 pyramidal cells. There's a bunch of other neurons in layer 4 and layer 2 granule cells and so on. But what drives this whole piece of the cortex are these pyramidal cells that are kind of going up and down. And it is forming a cell in here, and that cell essentially has a negative and a positive side. And if you tease that apart, you can see that these pyramidal cells are kind of in an arcade next to each other, and they're generating these action potentials in here. So the reason that a seizure comes from the cerebral cortex only and not from other parts of the brain is because there is a geometry to the cerebral cortex. And you're going to say, well, there's a geometry in cerebellum. Yeah, but cerebellum, most of the Purkinje cells kind of stop working, but they have continuous seizures, and there's inferior olive in there also that stops it. The rest of the brain, if you think of finding a voltage from them, is going to be very difficult, right? So let's say take basal ganglia. The cells are going all over the place. They go north, they go south, they go this way, and each one is going to be canceling each other. So you're not going to have a real jump on or ability to record a spike in there. And this is a normal EEG. So these little squiggles that you see from the top of the brain essentially comes from these cells that are in 2 directions. And then a number of these cells get together and form a battery, and that battery makes a negative and a positive in there. So this EEG that you see in here is a positive and a negative and a positive and a negative voltage. And we take this pattern, and since epileptologists are very smart, I'm not an epileptologist, they take this pattern and they make sense out of this. And that's a big deal, because we can look at this pattern and say, okay, this is normal, this is how the brain should operate, because it's kind of going on. Whereas if you come to a different one, and I'll show you some seizures, and then that will be abnormal. So synchronization of activity, the past one was showing that these cells are kind of which way and going along and firing, and they're forming a cells, and each cell is kind of having a positive, a negative, a positive, a negative, and that positive and negative is reflected here in EEG. In each one of these lines are a piece of the brain that's giving you that positive and negative. And now suddenly you synchronize all of those, and instead of that one cell, you have a whole battery that kind of goes up and down and a large spike. So then you have something like this, which is spike and wave there. So as you go along on the, let's say, frontal area to, this is a double banana, frontal to occipital over here, frontal, temporal, parietal, occipital, and then in the right side of the brain, you see that there are some big spikes. And these big spikes are basically synchronization of those pyramidal cells that I showed you, that instead of 1 or 2 cells, now you have a large number of cells together, they're firing and they're putting a big spike together. And if you look at it from a color perspective, here's a hippocampus, and these cells, each one is kind of colored, and they're firing at different times. So if you think of each color at different time of firing, if they are synchronized, suddenly all of them turn green here, and they fire at the same time and give you a little voltage jump here. And these voltage jumps are synchronizations of those neurons in there. Here is a right parieto-temporal seizure. As you can see, the seizure starts right over here somewhere. These are all kind of normal, not 100%, but kind of normal, but a seizure kind of starts putting, and this is the period of time. If you remember that the distance between each one of these vertical lines is 1 second. So that's 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6, 7, all the way up to here. This patient is experiencing an aura. Okay, as the these jumpy things move and this disruption moves into the front part of the brain into the other part and it spreads, then this patient is going to have a convulsion or a large seizure. But during this time, this is a parieto-temporal seizure, and this could be an aura itself. And if you ask the patient during this time, what's happening, what are you doing? Oh, I don't know, I smell something really weird, or I feel kind of funny in my right side or left side. Here's another one. It starts on the left side and kind of goes on, and as you go on, it's kind of picks up. So this is the beginning of the seizure, the middle of the seizure, and then at the end, it's going to be a post-ictal period. So, yeah. I thought I had another seizure, a seizure example also, but I guess I don't. So in the last 5 minutes, I'm going to talk a little bit about therapy. Just by numbers, there are 28 different anti-epileptic medications that are on the market right now. In general, one is not better than the other. So how do you approach in choosing them? It's kind of like going car shopping. You have your budget, you have what kind of car you want, where you're going to drive, and so on and so forth. And then you go to a car lot and there are 8 zillion brands. And the same with epileptic medications or hypertension medications. There are 8 zillion brands and you want to pick one. And the way you're going to pick them is you start from the beginning. The start from the beginning is do you want to treat or not treat? To treat or not treat is sort of the big question. The reason this comes up is oftentimes we don't know whether somebody has real epileptic seizure, because as I mentioned at the very beginning, a seizure is a abrupt cessation of brain function. It's not an operation issue because we don't see the operation of the brain, except sometimes during an EEG. If you have the EEG ready and all the stars are crossed, then you can see that. But in general, we sort of make a guess whether this patient had a seizure or not. And as you make more guesses and you go on and you get proven wrong often enough, then you learn a lot about it and you know clinically whether somebody has a seizure or not. So the reason that matters is because you want to make a decision whether to treat this patient or not treat this patient. If somebody has, let's say, every 2 months, an episode where they either pre-syncopize or just don't talk for a while and they're not looking at you and they're not responding, and they're a little old lady who is in a nursing home, I would be really reluctant to treat that. But if the same person has these things every month or so and they're a construction worker walking on a catwalk or driving a truck, I will think twice about not treating that person. So you can see that the treat or not treat has a lot of components. It's kind of, again, buying insurance, for example. So buying insurance means that you go to the insurance salesman and they ask you, well, how old are you? Have you had any accidents? What kind of car do you drive? Do you own your home? Blah, blah. And there's some racial things that have come up recently. Similarly, in seizure, you're going to say, okay, do you work somewhere weird? Do you have convulsions? Is your MRI normal? Is your EEG normal? If there is something wrong with the MRI and there's something wrong with the EEG, if you are working in a high-risk job, if you are, for example, not in a calm environment and you have to work at night, you would definitely treat those people. Whereas other people, again, the example is somebody in a nursing home who has a little stopping of function, 80-year-old, and we get this in consults all the time. Do you want to treat that or not? So that's how you approach the treat or not treat choice. Then what to choose for treatment? My approach is usually to think of pharmacodynamics and then go pharmacokinetics. And pharmacodynamics essentially are these medications. So sodium channel blockers are phenytoin, carbamazepine, lacosamide. There are GABA augmenters, which is valproate, benzos, barbiturates. There are NMDA blockers. These are kind of rare and they're not very effective. medications such as topiramate. And then the weirdest medicines are these two. Gabapentin was touted as one of the best medicines at the very beginning, that it stops the synaptic transmission because it increases the amount of GABA dipeptide. Turned out none of that was true, and gabapentin is a terrible medicine for seizures. It sometimes works for pain. Levetiracetam, on the other hand, will do the same thing, and just by, not because of research, not because of smartness, but just by grace of God, it turned out to be a very, very good medicine. It does everything that all of these old medications do without causing a lot of side effects and without you getting blood tests all the time. And you can use levetiracetam with bucket loads without side effects. So in many ways, our approach to pharmacology and whether you choose in every discipline, not just epilepsy, let's say HIV, right? The retroviral inhibitors the inhibitors of the retroviral enzymes didn't come because of NIH grants or anything else. It was because somebody was doing something in the lab and they saw that it was working, and NIH spent billions of dollars and didn't come up with a medicine for it. The same thing with the epilepsy. Levetiracetam somehow worked as a good medicine. There was felbamate that was by Wallace Laboratories, and there was a huge campaign in all these meetings, but it never panned out on anything. So we do have a bunch of medications. That's the good thing. There's 28 of them, and you can have choice. But the choice should be whether you want to choose based on pharmacodynamics and pharmacokinetics. Pharmacokinetics is, a lot of it is what body does to the drug, and then how does it affect you, which is side effects, and the side effects are kind of important. As you know, all of these old medicines have a ton of side effects. Phenytoin, if you take it for a long time, causes neuropathy, cerebellar degeneration, hirsutism, etc. Carbamazepine is relatively benign, but it causes hyponatremia and dizziness. Phenobarbital shaves 10 points off of your IQ. Valproate is going to make you fat, bald, and shaky. Also, it's pretty bad teratogen and causes liver problems. So these old medications are really good medicines. They're very effective in terms of preventing epilepsy, but also they have a ton of side effects. And the new ones that are here are not as effective, but they don't have as many side effects. Although if you really compare, you know that they all have side effects. Topiramate, for example, causes kidney stone. Lamotrigine is a pretty benign medicine. Gabapentin is a good medicine, but it doesn't work. Clobazam is good. You know, if you want to give people just benzodiazepines. But again, I put Keppra here on green. That sort of has become a very good, handy medicine to use. It is secreted through kidneys only. And as long as your kidneys are working, it's good. Some people, especially older people, can have side effects, and those side effects are psychiatric. That's why we call Keppra Keprage. So some of these side effects are kind of important to keep in mind and either give people Keppra. The best substitution for Keppra is lamotrigine. This causes Stevens-Johnson and rashes. So because of that, we kind of avoid that. But lacosamide is a good medicine also. So my go-to medications in general are levetiracetam, lacosamide, lamotrigine, and then some of the old medications. I love to give everybody valproate if it wasn't for its side effects and ammonia level, because on the brain, it works very well. So I'm gonna stop and leave about 5 minutes for questions. If there is any questions, please let me know.
Dr. Azizi, thank you very much for this great talk, and we do have questions for you. So one of the question is about the provoked seizures. You mentioned that, you know, it has to be because, and it makes sense, if somebody is, takes the medication and has a seizure, why majority of people don't have it and somebody has it. So, so what could be the mechanism of that? And I'm not talking about the clear-cut cases, somebody had a trauma scar in the brain, or history of stroke or something, but,
So that's where the controversy is, where people who are, I'm talking about, well, the modern people in general, and I don't consider myself modern, they think that there is a genetics to that. And all we have to do is to look for those genetic components and find the proteins that are structurally abnormal that then, in some people it causes seizures, and some people it doesn't. But a lot of the provoked seizures are very spurious. In fact, the ones I have seen are, these people drive themselves nuts and they have a seizure, and then then the whole question is, well, is there epilepsy in there? And they have damaged the brain to the point where they're going to have more seizures, or they don't. So if you go to older people, they will tell you, oh, there's no such a thing as provoked seizure. Everybody if you drive people down and they have a seizure, then that means they're going to be epileptic. And but that, again, one of the other points I was making throughout this whole talk is to separate treatment from diagnosis. In other words, every time you have a diagnosis of a seizure, do they really need to be treated? And should you treat or not treat? And that's another thing to go, because what it means is this provoked seizure is that, well, do you want to treat them or not treat them? If somebody comes with a provoked seizure in the emergency room, do you want to treat them or not? I have seen 50-50. Some people, we send them out and they don't come back ever. Other people definitely show up again a week later, 2 weeks later, and then you're going to say, yeah, I'm just going to give you the treatment. Okay. But majority of people come back for a seizure. When we call them as provoked seizure and we don't treat them, but they then come back and they do have epilepsy.
Now, talking about the seizure mechanism, why sleep deprivation that lowers that threshold for synchronization or risk increases? Okay.
And that is an amazing question. It goes into philosophy and all. So there is a idea of bantering about that seizure and sleep both are protective mechanisms by the brain to go to rest. In other words, manage its energy in a way that by synchronizing activity, your energetics are distributed differently than during normal waking situation. And that distribution of energetics and synchronization is a period of rest. So a seizure, in fact, is not necessarily something bad that's happening, but it is a reaction to a traumatic, energetic issue for the brain, and similarly sleep. So during sleep, as you know, sleep spindles and all that, and they, as we go to sleep, patches of brain synchronize. And that synchronization decreases the threshold for also going into sleep. And sleep deprivation is the other way around. You also are going to disrupt that operation of normal cycling of the brain. And that operation of normal cycling the brain is going to give you more sleep deprivation, can also cause seizures. Similarly, seizures are usually, when people have seizures, they're either when they're going to sleep and the brain is synchronizing, or when they're getting out of a deep sleep and the brain is synchronizing, they go into a seizure. So nocturnal or sleep epilepsies in general are during either going to sleep or coming out of sleep. And the whole idea in terms of the mechanism is fascinating and definitely not well understood. But one theory is that sleep and seizure are sort of the same. They're both synchronization of brain activity, and they both have to do with energy management in the brain. So because of that, they are kind of tied together.
So in a very simplistic way, if you lose that synchronization at night, if you're sleep deprived, the brain will synchronize you during the day, aka
right. So you can see that that's exactly.
In general, how long after the stroke does an older person start to develop seizures? Or, that epileptogenic period? Is it very individual, or there are some?
It's very, very individual. So just like management of blood pressure, we kind of go through 20 years of study upon study and then come back and they say, oh, the blood pressure management during stroke is individual. The same with seizure. It's extremely individual. But it is shown that large strokes usually do not cause seizures. It's the small embolic. And the reason for that, again, is that seizure is an active reorganization of the brain. With a large stroke, when you take a piece of brain out, you are not reorganizing anything. But it is the small strokes, the embolic strokes that are on the surface of the cortex that pushes the brain to reorganize. And that reorganization sometimes can become a seizure-producing thing. So a seizure, another thing about the seizure is that the seizure is a result of improper healing of the brain from an injury rather than a direct result of the injury itself.
Question about SUDEP. Who is at risk and how can we mitigate if we don't treat all first generalized seizures?
Everybody who has generalized seizure doesn't have SUDEP, and the SUDEP usually is the newest idea again is the 1-2 punch. For example, if the molecular mechanism of cell death is the same, and I'm bringing these analogies here. If the molecular mechanism of cell death is the same, why some people have ALS and some people have Alzheimer's and some people have Parkinson, it is because there is a whole concept of what's called 1-2 punch. The sucker punch is the genetics or whatever else that's in there in the bottom. And then the real punch that comes later, then that hits the person and it will be on that same. The same with seizure, with SUDEP. If you do have a cardiac issue to begin with, the cardiac arrhythmia, and then something happens as a secondary, and that is a seizure, and that seizure goes into the insular lobe, that insular lobe is going to cause the SUDEP. So again, it's a 1-2 punch as to why some people have SUDEP and when some people don't have SUDEP. How do you prevent that? It's basically during the seizure, is this person have ABC? In other words, airway, breathing, and circulation is okay. If the ABC is okay, then you're not going to have SUDEP. If the ABC is not okay during seizure, you either die or in the future, you have to make sure that they don't have a seizure.
I'm going to squeeze in one more question. Your thoughts and comments about cenobamate, the ex-Calvary medication. The newer,
of which medication?
Ex-Calvary, the cenobamate.
I don't know that medicine.
Okay.
Okay.
And then what is the significance of the length of the seizure?
Okay, significance of the length of the seizure is similar to the significance of the length of the post-ictal period, is a structural lesion underlying the brain. So people have a small structural lesion, they will have a seizure. But then a seizure that turns into a status epilepticus, it basically means that the kindling has occurred. And that kindling is either chemical or physical, meaning that you have a lesion in one area, and that area has produced a pathway that now if you have a seizure, that seizure becomes more difficult because it is kindled. So the concept of kindling is sort of important in there in terms of prolonged seizures. So the length of seizure is important. You know that the question may have been as to why it's minutes as opposed to syncope that's seconds. You can't knock out the brain and recover it immediately if it is coming from the brain itself within seconds. It's going to take a while. So that's why seizure is always minutes, whereas syncope is seconds. But then if a seizure is prolonged, then it turns either into semi-status epilepticus or status epilepticus. That means that brain is kindled. And the kindling means that either physically you can see by MRI that there is a large lesion in there, or as you don't see it, but the brain is highly sensitized in that circuit, that it goes into a seizure and stays there because of the long-term potentiations.
Dr. Azizi, thanks a lot. I'm getting good comments thanking you for the great lecture. Have a good day, everybody.